Okay, so we are going to start with my UWorld journal, and we're trying to see how many questions we can get through. Let's see. So, uh, the verse that we're going to go with today: "The Lord will fight for you. You need only to be still." Exodus 14:14. All right. With that, we shall start. Okay. So the very first question we have from my UWorld journal is squatting. Squatting increases venous return. Squatting increases venous return, so there will be more blood in the left ventricle. This will increase in cardiac output. What does that mean? Squatting. So when you're squatting, you are trying to increase the amount of blood that's coming back to the heart. Um, okay. So increased venous return, more blood in the left ventricle. This will increase cardiac output because when you're squatting, there'll be more blood going back to the right atrium. Therefore, if there's more blood in the right atrium, there'll be more blood in the right ventricle and left atrium and left ventricle, which will increase the cardiac output. Okay, and then next, let me see. Squatting here, you see this squatting. It increases the uh, squatting will increase the systemic vascular resistance because there'll be more blood flow, so the vascular resistance will also increase. And this is done in tetralogy of Fallot patients to improve the cyanosis. Okay, all right. Next, there's something. So here, squatting increases the preload, like we just said, because there'll be more blood coming back to the heart. So more blood in the right atrium, therefore more blood in the left ventricle. So preload is increased, and afterload in squatting is also increased in squatting due to TPR, total peripheral resistance, going up. So yeah, there's more blood, so TPR will go up, therefore afterload will also go up. And you see increased LV volume here. Okay, let's see, squatting, that's it. Alright, so what's going to happen when you stand? Standing will decrease the venous return, so that means less blood in the left ventricle. There will be decreased cardiac output when you stand. Alright. Now 3. Acute mitral regurgitation. What will happen in acute mitral regurgitation? Preload will go up, afterload will go down, um, ejection fraction will go up, contractile function, there's no change, and there will be decreased forward stroke volume and decreased cardiac output. Alright, so the reason acute mitral regurgitation, what's happening? Blood pumped into the left atrium goes into the left ventricle, but then goes back into the left atrium, causing both left atrium and left ventricle fluid overload because there's a leaky mitral valve. So the left atrium and left ventricle are bouncing back between fluid. So the preload, because the mitral valve is leaky, everything from the left atrium will go into the left ventricle, causing an increased preload. And here the afterload is decreased because the way I think of afterload is like the resistance to how much blood is being pumped out. So if there's a lot of blood in the left ventricle, there wouldn't be so much resistance to pumping from the left ventricle to the aorta. So I would imagine the afterload goes down. That's how I think of it. I know I just said For the other one, TPR increases in squatting because of more blood flow, so afterload will go up. I think that's like more of a unique situation, because in the other cases, I just imagine like the scenario of afterload is a resistant to the heart, to the left ventricle ejecting blood. That's the simplest way I think of it. So here there is a lot of blood in the left ventricle and mitral regurgitation. So that means if there's a lot of blood, that means that afterload will be decreased, because it's easy. There's so much blood to pump out. Why there's no resistance? You just pump it out. So afterload will be decreased, and then ejection fraction will be increased because ejection fraction is the total percentage of ejected blood from the left ventricle. So yeah, total percentage of ejected blood from the left ventricle. So there's a lot of blood in the left ventricle, so it's going to be there's more will be pumped out. All right. Contractile function, no change. Okay, there's no change in the contractility of the heart, and decreased forward stroke volume, and decreased cardiac output. Why is cardiac output decreased? Cardiac output is decreased because the amount of blood ejected from the left, it's cardiac output is the amount of blood ejected from the left ventricle per minute. So that is decreased in acute regurgitation. Sorry, acute mitral regurgitation. So there will be increase in diastolic volume, which is the amount of blood in the left ventricle before it is pumped out. Okay, so here, increased ventricular filling pressure. So you see increased ventricular filling pressure in mitral regurgitation and heart failure because of fluid overload. So there's too much fluid in mitral regurgitation and heart failure. Um, that's where you hear S3 heart sound and fluid overload. Okay, now that's different from S4 heart sound because S4 heart sound is when there's more pressure, like in hypertrophy. Um, yeah, so S3 has to do with fluid, S4 has to do with pressure. Okay, next. Um, so in let's see, acute mitral regurgitation, you see hypotension because of reduced cardiac output. Yeah, because the reduced cardiac output, you see hypotension. Ejection fraction will be up in mitral regurgitation. Ejection fraction is the total percentage of blood ejected from the left ventricle. That will be up because there's increased blood in the left ventricle. But cardiac output will be low. Okay, cardiac output will be low, so you see hypotension. Or decreased. Still lost to regurgitation. Yeah. So remember that, okay? Alright. Some basic formulas you want to remember. Stroke volume equals EDV. Yeah, stroke volume equals EDV minus ESV. The ejection fraction is stroke volume over N diastolic volume. Cardiac output is stroke volume into heart rate. Mean arterial pressure is cardiac output times TPR. Alright, 5-minute break. My cat needs me. Okay, we're back. Next, A beta lipoproteinemia is the inability to synthesize apolipoprotein B. Lipids absorbed by small intestine get stuck in the small intestine, absorptive cells like the enterocytes, and cannot be transported into the blood. Okay. You see very low serum triglyceride and cholesterol levels. And then you see bulky, fatty, greasy stool. You see enterocytes with clear or foamy cytoplasm, which actually are the lipids stuck in the small intestine. Enterocytes. A beta lipoproteinemia, inability to synthesize apolipoprotein B, lipids absorbed by the small intestine, um, get stuck in the small intestine, absorptive cells and enterocytes, and cannot be transported into the blood. So you see very low serum triglyceride and cholesterol levels and bulky, fatty, greasy stool. So you see enterocytes with clear or foamy cytoplasm, which actually are the lipids stuck in the small intestine. Enterocytes. Most common cause of A beta lipoproteinemia is a loss of function mutation in the MTP gene. Most common cause of A beta lipoproteinemia is a loss of function mutation in the MTP gene. Okay, next we have acute appendicitis. Here you have retained mucus. Retained mucus causes appendix wall to distend, which impairs venous outflow. This leads to hypoxia of the wall, and this leads to ischemia of wall of appendix. Bacteria leaks out through the appendix of the wall, and then you get inflammation and edema of the wall. Okay, necrosis. Then you get necrosis and rupture of the appendix wall. All bacterial contents spill into the peritoneum, causing peritonitis and septicemia. Okay, so acute appendicitis. Retained mucus causes appendix wall to distend because the mucus keeps building up in the appendix, compressing blood vessels of the appendix. This impairs venous outflow. Then you get hypoxia of the wall, and then you get ischemia of the wall of the appendix. Bacteria leaks out through appendixal wall, and then you get inflammation and edema of the wall, then necrosis and rupture of the appendix wall. All bacterial contents spill into the peritoneum, and you get peritonitis, and then you get septicemia. So first, you have in acute appendicitis, you have periumbilical pain. So you have pain around your belly button. Then that pain shifts to the right lower quadrant. Okay. So first, it's the periumbilical pain, and then the pain shifts to the right lower quadrant. Most common cause of acute appendicitis. What is that? It is obstruction of the appendicular lumen. Most obstructing agent is a fecalith. Okay. Most common cause of acute appendicitis is obstruction of appendicular lumen. Most common obstructing agent is fecalith. So here the tube of the appendix is blocked by a poop rock, but pressure still builds up on the appendix, causing it to burst. Alright, next. Long-standing ulcerative colitis is associated with an increased risk of colorectal carcinoma. Colorectal carcinoma in IBD patients usually develop after 10 years of colitis. Long-standing ulcerative colitis is associated with increased risk of colorectal carcinoma. Colorectal carcinoma in IBD patients usually develop after 10 years of colitis. Colitis-associated carcinomas are most likely to arise from non-polypoid, which means flat, non-polypoid dysplastic lesions, be multifocal in nature, develop early p53 mutations, and late APC gene in late APC gene mutations and be of a higher histological grade. Okay, and will appear mucinous and or have signet ring morphology and will affect younger patients more. Okay, so ulcerative colitis has increased risk of colorectal carcinoma, and then in IBD patients, you after 10 years of colitis, you can get colorectal carcinoma because the constant inflammation of your intestines. Okay, so then colitis associated carcinoma are most likely to arise from flat dysplastic lesions, be multifocal in nature. They develop early p53 mutations. What's p53? It's a tumor suppressor gene. So that the thing that suppresses your tumor is mutated. So there's nothing to suppress a tumor. So it goes crazy. That's how you get cancer. And then it's also colitis associated carcinoma is also associated with late APC gene mutations and be of a higher histological grade and appears more in young people, and you will see a signet ring morphology. Let me show you the signet ring morphology. Signet ring morphology. Ulcerative carcinoma. Colorectal. So this is a signet ring cell. See, all these are cells with the nucleus to one side, and a huge cytoplasm. Okay, look at this. If you can look at this, you can see the cells. For example, take this. The nucleus is off to the side, and you see a huge cytoplasm. This is a colorectal carcinoma. It's a feature of colorectal carcinoma. All right. Okay. Oops. Let's see. All right. Now, wrong. All right. Next. The reason elastin is able to recoil is due to its unique ability. The reason elastin is able to recoil is due to its unique ability of desmosine cross-linking between 4 different lysine residues on 4 different elastin chains. The cross-linking is accomplished by the action of extracellular lysyl hydroxylase. Okay, the reason elastin is able to recoil is due to its unique ability of desmosine cross-linking between 4 different lysine residues on 4 different elastin chains. The cross-linking is accomplished by the action of extracellular lysyl hydroxylase. Alright, so this is like biochem. Not my strong subject, but so this is the reason elastin is able to recoil. Because of desmosine cross-linking between 4 different lysine residues on 4 different elastin chains. The cross-linking is accomplished by the action of extracellular lysyl hydroxylase. Next, triple helix formation in collagen is initiated by hydroxylation, glycoxylation, and interchain disulfide bridges at the C-terminus of procollagen molecule. This modification does not occur in the formation of elastin molecules. So triple helix formation in collagen is initiated by hydroxylation, glycoxylation, and interchain disulfide bridges at the C-terminus of procollagen molecule. By hydroxylation, glycoxylation, interchain disulfide bridges at the C-terminus upper collagen molecule by hydroxylation, glycoxylation, and interchain disulfide bridges at the C-terminus upper collagen molecule. This modification does not occur in the formation of elastin molecule. Okay. Next, we have streptomycin. Streptomycin inhibits the initiation of protein synthesis by binding to and distorting the structure of prokaryotic 30S ribosomal subunit. Streptomycin inhibits the initiation of protein synthesis by binding to and distorting the structure of the prokaryotic 30S ribosomal subunit. Okay, Lyme disease. It comes in 3 stages. The first one is early localized phase, days to weeks following exposure. Days to weeks following exposure. Patients experience flu-like symptoms and erythema chronicum migrans in the first stage. Erythema. So this is the very first stage of Lyme disease. Early localized phase, days to weeks following exposure. Patients experience flu-like symptoms and erythema chronicum migrans. The second stage of Lyme disease is early disseminated phase, which happens weeks or months later. There will be brain involvement and or cardiac involvement, such as cardiac involvement, and you can also what you see is Bell's palsy or AV nodal block. Bell's palsy is this. Half your face is droopy. So this is Bell's palsy, okay? Does she have it? I don't think so. She looks fine. That's not what Bell's palsy looks like, even if she does have it. So Bell's palsy looks like this. Okay, so this guy is trying to smile. His left side is working, his right side is not working. See that? Okay, so his left side is the only one that's, dear goodness. Okay, so the right side is not working, his left side is the only one that's working. This man is trying to smile, but he could only smile on his left side, and on his right side he can't smile. See this? So his right side is paralyzed. That's Bell's palsy. And you have AV nodal block also, which is atrioventricular block, and that's the second stage of Lyme disease. Okay. Now the third stage is chronic Lyme disease. It's rare. Chronic Lyme disease. It's rare. It's months to years post exposure. Patients experience asymmetric arthritis, most involving a single knee joint, and subacute encephalopathy with symptoms of decreased memory, somnolence, and mood changes. So basically, you have one knee that's affected in um, chronic Lyme disease, and you have subacute encephalopathy with symptom of decreased memory, somnolence, and mood changes. All right. So Lyme disease can be treated with doxycycline or penicillin type antibiotics or ceftriaxone. Lyme disease is caused by Borrelia burgdorferi. Number 9. Acute gouty arthritis. You give NSAIDs, that's first line. Um, colchicine is sometimes used too. Colchicine mechanism of action is inhibition of microtubular polymerization. Colchicine binds to the protein subunit of microtubules and prevents their aggregation. Okay. Colchicine binds to the protein subunit of microtubules and prevents their aggregation. Colchicine also reduces formation of leukotriene B4. So to recap, colchicine inhibits leukocyte migration and phagocytosis by blocking tubulin polymerization. Most serious side effects of colchicine is nausea and diarrhea. Colchicine is contraindicated in elderly people and renal dysfunction patients. Okay. Okay. So acute gouty arthritis, NSAIDs is first line. Colchicine. Colchicine is used for gout. Well, I suppose we're off from the beginning. Colchicine. Yeah, colchicine is for gout. Drugs that act on microtubules: mebendazole, griseofulvin, colchicine, vincristine, vinblastine, paxilotil. Okay, so these acts on the microtubules. Okay. So for gout, the treatment for acute gout, it is an NSAIDs, which is endomethacin. You can also give colchicine. Um, okay, that's why. And then colchicine, it affects the microtubular formation. All right. You don't give it in people with renal dysfunction and old people. So, the most common cause of spontaneous intracranial hemorrhage in young adults are arteriovenous malformations, ruptured cerebral aneurysms, or abuse of increased sympathetic drugs like cocaine. So the most common cause of spontaneous intracranial hemorrhage in young adults are arteriovenous malformations, ruptured cerebral aneurysms, or abuse of increased sympathetic drugs like cocaine. Okay, now we're on. We're done. Coarctation of aorta is associated with Berry aneurysms and of the circle of Willis. Berry aneurysms are very prone to rupture when associated with coarctation because of hypertension in branches of the aortic arch proximal to the coarct. The result is subarachnoid hemorrhage. Patients with adult type coarctation of the aorta die of hypertension associated complications like left ventricular failure, ruptured dissecting aortic aneurysm, and intracranial hemorrhage. These patients with congenital coarctation of aorta are at increased risk for ruptured intracranial aneurysms because of increased incidence of congenital Berry aneurysms of the circle of Willis as well as aortic arch hypertension. So patients with congenital coarctation of the aorta are at increased risk for ruptured intracranial aneurysms because of increased incidence of congenital Berry aneurysms of the circle of Willis as well as the aortic arch hypertension. They get subarachnoid hemorrhage. Number 11. Hypercoagulability occurs because adenocarcinomas produce a thromboplastin-like substance that is capable of causing chronic coagulations that are both disseminated and tend to migrate. Migratory thrombophlebitis should always make you think cancer. Migratory thrombophlebitis, aka Trisell syndrome. Trisell syndrome is especially seen in pancreas, lung, and colon cancer. So hypercoagulability occurs because adenocarcinomas produce a thromboplastin-like substance that is capable of causing chronic coagulations that are both disseminated and tend to migrate. Migratory thrombophlebitis should always make you think cancer. Migratory thrombophlebitis, aka Trisell syndrome, is especially seen in pancreas, lung, and colon cancer. Okay, so this is Trisell syndrome. Migratory thrombophlebitis associated with pancreatic cancer. So what this is So migratory thrombophlebitis. So pain in the part of the body's redness, lumps under the skin. All right. So that's Trisau syndrome. It's a sign of pancreatic cancer, and colon cancer. Pancreatic cancer has one of the worst outcomes. That's just. Migratory thrombophlebitis should always make you think cancer. Okay, so it's because there's a thromboplastin-like substance that is capable of causing chronic coagulations that are both disseminated and tend to migrate. I wonder if this is itchy. Hold on, let me look. Yeah. So I think I remember a question where they said that the patient is swollen, like the hands and feet. They are red, and also the patient is experiencing intense itchiness, and it keeps moving, it keeps going from place to place. So, and that patient had cancer. So that patient, specifically, the patient had Trisel syndrome, which is migratory thrombophlebitis. It is a thromboplastin-like substance that's what's causing the coagulations, and then it moves from your hands to your feet and back up. So yeah. Next, most antidepressants target the neurotransmitter serotonin. SSRIs inhibit serotonin reuptake by blocking SCRT. This prevents the normal reuptake of serotonin into the presynaptic neuron, which will lead to increased serotonin in the synaptic space and cleft. So what they're saying is SSRIs, selective serotonin reuptake inhibitors given for antidepressants, increase the amount of serotonin in the synaptic space or cleft. Next, advance directives consist of two main components, a living will and a health care proxy. A living will specifies the patient's end-of-life wishes and includes specific directives regarding intubation, cardiopulmonary resuscitation, enteral feeding, and other life-prolonging interventions. So um, that is a living will. It specifies what the patient wants regarding if they want to be intubated, if they want to be DNR, if they want to be on a feeding tube or a ventilator. That's a living will. Okay, a healthcare proxy um, is a healthcare proxy document allows the patient to designate a specific individual to make healthcare decisions should the person become incapacitated. All right, so two ways, two ways a patient uh, can like leave should they become unconscious or they can't make a decision for themselves. It's called advance directive. There's two types: a living will and a healthcare proxy. All right, 14. If an elderly man forgets to take his medications, even though there is a caregiver, which is his daughter, at home, The next time he comes in with complications of not taking his medications, it is your duty as a doctor to ensure that there is involvement of a social worker in his discharge planning. Social workers can determine whether the patient has adequate family or caregiver support at home. Okay, so even if a old man is living with his daughter and he's not taking his medications because he forgot or he just doesn't want to, you have to make sure there's a social worker involved in his discharge planning. Next, anorexia nervosa. You say bradycardia, you say hypotension, you say osteoporosis, amenorrhea, lanugo or hair loss, enlarged parotid glands, if it's the binge and purge type, and cardiac issues like cardiac atrophy, cardiomyopathy, arrhythmias. Amenorrhea is not a requirement for diagnosis anymore. Um, yeah. So anorexia, there's a restriction type. This was the one that engages in extreme calorie restriction and exercise. There's the binge eating purging type, which engages in purging, self-induced vomiting, misuse of laxatives and diuretics. Patients who induce vomiting usually have parotid gland hypertrophy. I'm gonna show you this. So parotid gland, parotid gland, gland hypertrophy. Okay, so this is what this is. Parotid gland hypertrophy. So the parotid gland is enlarged right here. Let's see if you can see it here. You can slightly see it, but this is the better picture. Okay. All right, that's seen in. It can be seen in binge eating disorder. It can be seen in bulimia nervosa. It can be seen in anorexia, but only the anorexia has a few subtypes. It can anorexia nervosa. This one is seen in the binge eating purging type. So they eat food and then they stick their fingers down their throat and induce vomiting, and this causes enlarged parotid. Okay. So patients who have vomiting usually have parotid gland hypertrophy, dental caries, halitosis, and calluses on the dorsum of their hands. This is known as Russell sign. I'm going to show you what Russell sign is, okay? So if you see this on a patient, suspecting eating disorder, because this means that they're inducing vomiting. Oh my goodness. Would they leave this girl alone? Okay, that's not even a proper picture. Alright, so this right here, this is Russell sign, okay? This is Russell sign. Alright, now, next. Psychogenic stress accounts for about 8-10% of cases and include performance anxiety, sexual partner dissatisfaction, and marital problems. Important clues that point towards psychogenic impotence is sudden onset and morning erections. Vasectomy does not result in impotence, especially if it was done years ago. A recent pelvic trauma, prostate surgery, or priapism can lead to erectile dysfunction. SSRIs and sympathetic blockers like clonidine, methyl-dopa, beta blockers can cause erectile dysfunction. Okay. So psychogenic stress accounts for 10% of cases and include performance anxiety. Okay. So if you're stressed out, you can get erectile dysfunction. So vasectomy does not result in impotence, especially if it was done years ago. But if you have recent pelvic trauma, prostate surgery, priapism, or if you're taking SSRIs or clonidine, methyl-dopa, beta blockers, it can cause erectile dysfunction. Okay. Number 13. Consent from spouse is not required for sterilization. However, doctor should counsel the patient regarding the risks and benefits and alternatives to the sterilization treatment. Heterophile antibody test, if positive. Okay, we did go through this. Where do you see a positive heterophile antibody test? I believe it was mono EBV. Yes, heterophile antibody test. If positive means you are positive for infectious mononucleosis, which is caused by Epstein-Barr virus. Patients present with fever, sore throat, fatigue, lymphadenopathy, tonsillar exudates, and sometimes hepatosplenomegaly. Patients with mononucleosis must be careful about splenic rupture. Athletes are recommended to wait at least 1 month before playing again. So the biggest complication of mono is a rupture of the spleen. So we had to be very careful about that. Let's look at EBV real fast. Okay. UVV heterophile UC heterophile antibodies. Let's see. Okay, so here we have herpes virus. Okay, so Epstein-Barr virus is a type of herpes virus. It's under the family of herpes. Um, it is HHV4 um, respiratory secretions is transmitted by the respiratory secretions through saliva and the kissing disease. So it's known as the kissing disease because it's transmitted by saliva. It's common in teens, young adults, college kids. Okay, so mononucleosis, fever, hepatosplenomegaly, pharyngitis, lymphadenopathy, especially posterior cervical nodes. Avoid contact sports until resolution due to risk of splenic rupture associated with lymphomas. Um, there's like three types: endemic Burkitt lymphoma, nasopharyngeal carcinoma, and lympho. No, and the other one is a Hodgkin's lymphoma. Just make sure. Yep, it's Hodgkin's lymphoma where you see Reed Sternberg cells, and you also see. The second type of causes is that nasopharyngeal carcinoma, and so the first type of causes is Burkitt lymphoma. Number two is nasopharyngeal carcinoma, and then Hodgkin's lymphoma. So three types of lymphomas. Okay, and Hodgkin's lymphoma is where you see Reed Sternberg cells. Okay, next. Hypothyroidism causes depression. Normal THS level is 0.5 to 5. Uh, so if you have hypothyroidism, it can cause depression. That's why I always want to screen for somebody that comes in with depression. You have to screen for their thyroid levels because low thyroid level can cause depression. Normal level is 0.5 to 0.5 to 5. So if somebody's T3 and T4 level is 0.1, they have hypothyroidism. Alright. So that means you just need to fix their thyroid level and their depression will go away. For example, if a patient's TSH level is 15.2, then this person has hypothyroidism, and hypothyroidism causes depression. So remember this before prescribing antidepressants. So if somebody has a 15.2 TSH level, then their T3 and T4 will be low. This is hypothyroidism. Okay. So 19, discussing about non-compliance to medication should begin with a non-judgmental, open-ended question. So whenever you see questions, ethics questions, try to go for like open-ended questions, so the patient can talk more with you, and you will come off non-judgmental. Okay, discussion about non-compliance to medication should begin with non-judgmental, open-ended questions. Number 20, body dysmorphic disorder. It means that they're preoccupied with a perceived defect in appearance that is not obvious to others. In addition to the preoccupation, patients perform repetitive behaviors. Excessive mirror checking, grooming, or mental acts comparing to others. So remember, don't get this confused with OCD. This body dysmorphic disorder, they think they are ugly. There's something wrong. They think there is something wrong with them, even though they may look absolutely fine to everybody else. Um, it looks like they're very preoccupied, spend a lot of the time in the mirror, in front of the mirror, um, do a lot of repetitive behaviors, grooming, mental acts compared to others. So yeah, that's a body dysmorphic disorder. A health maintenance organization (HMO) is an insurance plan with low monthly premiums, like low co-payments and deductibles, and low total cost for the patient. HMOs reduce utilization by confining patients to a limited panel of providers, which requires referral from a PCP prior to specialist consultations, and denying payment for services that do not need established guidelines that do not meet established guidelines. Um, so HMO is an insurance plan that the patient pays low monthly premiums, um, but you need to go to a primary care provider first. You can't before going to a specialist. Um, and these HMOs, like they can deny payment for services that they do not feel like meet guidelines. Number 22, Medicare is a federal health insurance program. Medicare covers patients who are 65 or older, people who are disabled, and number 3, end-stage renal disease patients. Okay. And that's Medicare. Point of service plans are similar to HMOs. The point of service plans can also see out-of-network providers, and point of service plans have higher premiums and deductibles than HMO plans. So point of service plans are much more expensive than HMOs, okay? And then number 24, dysthymia. Okay, they love dysthymia and cyclothymia. So we're going to dysthymia first. Dysthymia is chronic depressed mood and at least 2 other depressive symptoms lasting for at least 2 years. So dysthymia is a chronic depressed mood and at least 2 other depressive symptoms lasting for at least 2 years. So you cannot be symptom free for more than 2 months. Depressive symptoms for more than 2 years rules out a diagnosis of major depression, and it makes it dysthymia. Dysthymia is different from cyclothymia in that dysthymia is 2 years of depression on and off, and cyclothymia is 2 years of fleeting depression. So 2 weeks at a time or less with periods of hypomania. Alright, so dysthymia is different from cyclothymia in that dysthymia is 2 years of depression on and off, and cyclothymia is 2 years of fleeting depression. 2 weeks at a time or less, you have depression with periods of hypomania. So cyclothymia has it has a touch of bipolar disease. Dysthymia is you're depressed for 2 years with at least 2 other depressive symptoms. So 2 other symptoms of Siggy Caps. If you guys remember Siggy Caps. So this is Siggy Cap. So basically, in dysthymia, you have to be depressed, along with any 2 of these symptoms, and that is the dysthymia. Okay. You cannot be symptom free for more than 2 months. with dysthymia. So you had to be depressed for 10 months out of the year for 2 years. So 10 months out of the first year, you had to be depressed, and for the second year, you had to be depressed for 10 months out of the second year to be diagnosed with dysthymia. Now, depressive symptoms for more than 2 years rules out a diagnosis of MDD, which is major depressive disorder, and makes it dysthymia. Dysthymia is different from cyclothymia in that dysthymia is 2 years of depression on and off, and cyclothymia is 2 years of fleeting depression. 2 years of fleeting depression. So you have depression 2 weeks at a time or less with periods of hypomania. Alright. Okay. Now 25. Older patients should be addressed formally by their last name at first, then asked what are their preferred names, how they want to be called. We should always address the patient by last name out of respect. 26. Capitation is an arrangement in which payer, which is the hospital, pays a fixed predetermined fee to provide all services required by the patient. Payouts will negotiate a capacitated contract with an insurance company that will then pay the providers. Okay, or a large medical group may negotiate directly with the payer, some other big hospital or insurance company. So here the hospital pays the insurance company, and the insurance company finds doctors who care for patients. Or it could be a payer, which is a hospital or insurance company, pays a large medical group, which will then provide service to its employees, it's like the hospital's employees, in exchange for money. This is a very hard concept for me to understand, but capitation is an arrangement in which a hospital pays a fixed fee to provide services required by the patient, and then the hospital will negotiate a contract with the insurance company that will then pay their providers. Or a large medical group may negotiate directly with the hospital. So the hospital pays the insurance company, and the insurance company finds doctors who to care for the patient. Okay. And payer, which is the hospital, pays a large medical group. Yeah, pays a large medical group. The hospital pays a large medical group, which then provides service to its employees in exchange for money. So this question, if I get something like that, I'm just going to recite what I said now, and I'm going to pick the most similar answer choice because I have no idea what they're actually saying. This is why I can't do paperwork. I don't know what's happening. 27. Fever and change in color or sputum are seen in viral airway infections, and antibiotics are not needed for this. Adverse effects of antibiotics is a GI upset, photosensitivity. That means you just can't tolerate light. Photosensitivity. Photosensitivity. Yeah, that means your skin will become red and inflamed when you step out in daylight. Okay. So, fever and change in color of sputum are seen in viral airway infections. Fever and change of color Okay, fever and change in color sputum are seen in viral airway infections, and antibiotics are not needed for this. Um, Adverse effects of antibiotics this will cause a GI upset, photosensitivity, modification in functioning of cytochrome P450 enzymes, which may cause toxicities from other drugs. Toxicities from other drugs. Okay. Also, antibiotics. Okay, so um, we'll get into that. Um, and I think this is talking about the cytochrome P450 enzymes. There's a group of drugs that are inhibitors and inducers. We have to get into that to understand. So just so you know, um, fever and change in color sputum are seen in viral infections. You don't give antibiotics for viral infections. Okay. Adverse effect of antibiotics. It can cause functioning issues, the cytochrome P450 enzymes. Okay, next. 28. Patients who are incapacitated should not be able to make healthcare. Patients who are incapacitated should not be able to make healthcare decisions. This includes being drunk and wanting to leave the hospital. You cannot let them go. Blood alcohol levels above 100 mg per deciliter, or 0.10 BAC tend to result in intoxication, slurred speech, and impaired decision-making capacity. So blood alcohol levels above 200 or 200 mg per deciliter or 0.20% are associated with marked motor impairment, loss of consciousness, and memory blackout. Okay. Um, what is allowed blood alcohol level? Allowed blood alcohol level. Okay, the legal blood alcohol content for drivers 21 and older in most U.S. states is 0.08. Okay, if your blood alcohol level is above 0.08, you're intoxicated. That's a DUI, okay? Don't drink. People say don't drink and drive. I just go ahead and say don't drink. So no temptation. Alright? Now, let's see. So anything over 0.10 blood alcohol level, 0.10 blood alcohol, 0.10, 0.10 at blood alcohol level, that is intoxication, slurred speech, impaired decision-making capacity. So if a patient presents to the ED like this, you cannot let them go. It's illegal. You have to wait and take care of them. 29. Sleep deprivation in doctors causes cognitive impairment, resulting in medical errors. Anything more than 17 hours of being awake is likely to result in medical and judgment errors because it's comparable to alcohol intoxicated individuals. So please sleep. Anything more than 17 hours of being awake is like you were intoxicated, and it can cause harm to the patient. Okay, like that's dangerous. It's really dangerous. This is different from physician burnout because physician burnout refers to a state of emotional exhaustion, synchronism, depersonalization, decreased sense of personal accomplishment, which can result in suboptimal patient care and medical errors. Someone who was exhibiting signs of burnout would be callous and have a lack of concern toward patients and their care. Sleep deprivation leads to forgetfulness, which happens when physicians get worn out. That's a physician fatigue. That's sleep deprivation. It's like you start forgetting stuff. You're just burnt out at that point. No. Oh gosh. Sleep deprivation leads to forgetfulness, which happens when physicians get worn out. It's physician fatigue. When you don't sleep and you're awake for more than 17 hours, that's sleep deprivation. And physician burnout is when you're just emotionally exhausted. Um, and they're callous, they're rude. Um, that's how you can differentiate synchronism. Yeah, synchronism. How do you say that word?
Cynicism.
Cynicism. Synchronism is a side effect of quinidine. Okay, that causes ringing in the ears. This is
Cynicism.
cynicism. So somebody that is emotionally burnt out, a doctor that is emotionally burnt out, um, will be
Cynicism.
will have cynicism. And this is an inclination to believe that people are motivated purely by self-interest. Okay, so this is like an egotistical thing. All right. Okay. So that's the difference between physician fatigue um, physician fatigue uh, and physician burnout. 30. If a patient says he does not want to know his diagnosis, for example, if his biopsy is positive for lung cancer, and the patient says he does not want to know if it's cancer, you as a doctor should not tell him. A competent patient has a right to refuse diagnostic information. The initial step from the doctor is to ask and explore why the patient feels this way. 31. Beta adrenergic antagonists are beta blockers. Beta blockers bind to the beta adrenal receptors. This blocks the binding of norepinephrine and epinephrine to the beta adrenal receptors. This is why beta blockers block sympathetic activity. They decrease heart rate and blood pressure. Beta adrenergic symptoms can blunt symptoms of hypoglycemia. Be careful while giving beta blockers to diabetics because beta blockers can mask hypoglycemia. Okay, so beta adrenergic antagonists or beta blockers. Beta blockers bind to beta adrenal receptors. This blocks the binding of norepinephrine and epinephrine to the beta adrenal receptors. This is why beta blockers block sympathetic activity. Okay. This is why beta blockers block sympathetic activity. They decrease heart rate and BP. Beta adrenergic symptoms can blunt symptoms of hypoglycemia. Be careful while giving beta blockers to diabetics. 32. Afebrile and thick yellow sputum and no signs of bacterial infiltrates on chest X-ray point to a viral infection. This rules out bacterial infection and therefore no antibiotics are indicated. So this was a question about somebody who did not have a fever and they had thick yellow sputum and no signs of bacterial infiltrate on the chest X-ray. This points to a viral infection. No antibiotics are indicated at this time. Alright? Because it's a viral infection. Antibiotics are only for bacterial infection. 32. Beta blockers and angiotensin converting enzyme help improve BP and outcomes after myocardial infarction as opposed to calcium channel blockers. So beta blockers and angiotensin converting enzyme help improve BP outcomes after MI as opposed to calcium channel blockers. So, beta blockers and I think they're talking about ACE inhibitors. Okay, let's look it up. Uh, Okay. So ACE inhibitors are angiotensin 2 receptor blockers, beta blockers, and spironolactone decrease mortality. Okay. Loop and thiazide diuretics are used mainly for symptomatic relief. Hydralazine with nitrate therapy improves both symptoms and mortality in some patients. Alright. So, somebody with heart failure, ACE inhibitors are, which are angiotensin converting enzyme inhibitors, or angiotensin 2 receptor blockers, beta blockers, and spironolactone, all decrease mortality. Okay, so that's what that means. Um, Beta blockers and angiotensin converting enzyme and angiotensin converting enzyme inhibitors help improve BP and BP outcomes after myocardial infarction as opposed to calcium channel blockers. 33. The process of transferring responsibility for medical care is referred to as a patient handoff, with sign out referring to the process of transmitting information about the patient and needed follow-up care. Using standardized patient handoffs that use a structured process eliminate overlooking important details and communication failures. Okay, the process of transferring responsibility for medical care is referred to as a patient handoff. Okay, the process of transferring responsibility for medical care is referred to as a patient handoff, with a sign out referring to the process of transmitting information about the patient and needed follow-up care. Using standardized patient handoffs that use a structured process eliminate overlooking important details and communication failures. So this is a way, using standardized patient handoffs is a way to efficiently eliminate overlooking important details and communication failures. The morning shift transmits info about the patient to the night shift using standardized patient handoffs to not miss any details regarding patient care. Okay, standardized patient handoffs. Now, 34. Patients with terminal illness, like advanced metastatic cancers, and those with a life expectancy of less than 6 months, should be considered for hospice care. Hospice care is based on the principle of providing compassionate care, which focuses on comfort and quality of care. So hospice care is based on the principle of providing compassionate care. Yeah, hospice care is based on the principle of providing compassionate care, which focuses on comfort and quality of care. They have a hospice physician who closely coordinates with the patient's attending physician. Hospice can be at a patient's home, nursing home, or dedicated hospice facility. But the requirements for going to hospice is that you have to have a terminal illness that is 6 months. That has a life expectancy of 6 months or less. Okay. So okay, so there was a question about a woman coming in and asking if she can take a herbal supplement, and you had to be careful and you had to read the ingredients and see if they have potential side effect. All right, hold on. Because, for example, a herbal supplement, Ephedra, marketed as a diet pill and energy booster, was banned by the FDA in 2004 due to the risk of CVS complications. It increases the BP, heart attack, and stroke. However, ephedra-containing products are still readily available on the internet. Ephedra plus caffeine induce adverse cardiac events. So pills like these and other herbal pills are poorly regulated by the FDA, so patients should be careful taking them. Okay. So if somebody comes in, you can't tell them no, don't use it, but unless it's illegal, of course. But you have to read for you have to read for the ingredients of the herbal supplement, see if it interacts with any of the patient's current medications. But no, you can't just tell them no. You have to try to incorporate their their views, holistic approaches into the care. So 35 is open-ended questions are most effective way to begin history of present illness. Once patient provides an initial history, the doctor can use closed-ended and follow-up questions to clarify certain points and gray areas. So you want to start with open-ended question um, to begin a history of the to begin the history of the present illness. Okay. 36, a discharge summary by the hospital doctor to document the hospital course and assist other medical providers with the care of the patient. A discharge summary by the hospital doctor to document the hospital course and assist other medical providers with the care of the patient. It uses medical language which may be confusing to the patient. It uses medical language which may be confusing to the patient. In contrast, the discharge instruction checklist uses simple and clear language intended to optimize the patient understanding. So, for the patient, you want to give them a discharge checklist. Okay, a discharge summary is what the hospital doctor uses um, to outline the hospital course and treatment um, and assist other doctors and nurses with the care. But for the patient, you want to give them a discharge checklist. Okay? Discharge checklist so they can understand um, what they're supposed to do and the medications better and when to take them better. 37. It is unethical to disclose any patient info, even in including the info confirming a person is indeed your patient with other doctors that are not caring for that particular person. So you can disclose info with other doctors that are caring for that patient, but you have to say no. I cannot say whether she is my patient. So basically, if a doctor, you and your doctor friend are having lunch together, and one lady comes up to you and um, she just has small talk with the one with the one patient. Well, we don't know if it's a patient; she's a lady, and you know the one doctor is a oncologist, and he's sitting down yeah, he's sitting down having lunch. The other doctor is OB-GYN doctor, and the oncologist recognizes the lady from like 5 years ago, and because that was her patient, and now she's in remission. Well, last that he met her, she was in remission, and the oncologist asked the OB-GYN, "Oh, how do you know her?" OB-GYN doctor cannot tell her, "Oh, she's my patient. She came in for a pap smear," or she's undergoing fertility treatment. He cannot say that. You have to say, like, basically, the doctor says, "Oh, she was my patient. We treated her for ovarian cancer or whatever." So the other doctor, who is the OB-GYN doctor, cannot confirm why the woman is being seen, or if she's being seen even as a patient. You gotta say, "No, I cannot say whether she's my patient or not." 38, bulimia. You having